The broadcast is now starting. All attendees are in listen-only mode.
Thank you for attending today. We'll be starting our webinar in about 1 minute. Please stay tuned.
Muted.
Hello, welcome everyone. My name is Cheryl Fatabeni, and I wanted to thank everybody for being with us today for our Lunch and Learn.
Unmuted.
On behalf of the National Nurse-Led Care Consortium and the AANP, we will be presenting the CAHPS survey and healthcare reform, what you need to know. Our presenter today will be Dale Schaller, and we will be moving forward with our presentation and recording today's presentation. Just a couple of housekeeping items to let everybody know that today's webinar is being recorded and will be available in the upcoming week on our Nurse Practitioner Support and Alignment portal page. The information for that will be at the end of the webinar, and a link to the recording will be sent to all registrants. All participants will be muted throughout the presentation. I encourage you to submit questions. Please use the Questions tab on your GoToWebinar control panel as seen here to ask your question. It will be relayed to the presenters or to the presenter today and answered at the end of the webinar. A survey will pop up also at the end of the webinar and will be sent in an email later today. Please take a few minutes to complete this survey evaluating this activity, as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available as a handout, which you can access via the Handouts pane in your control panel. You can click the name of the handout and it will be downloaded via your default web browser. At this point, I'd like to turn things over to my colleague at the ANP, Joseph, to tell you how you can receive free CE credit for today's presentation.
Hello everyone, today's presentation is accredited for continuing education credit by the American Association of Nurse Practitioners. For those who are interested in receiving CE credit, you will be required to attend at least 55 minutes of today's presentation. And in addition to that, you are required to access and connect to the presentation slide deck. So you have to be viewing the presentation in real time. Participants who are currently phoned in only, who have phoned in only and who want to receive CE credit, go ahead and dial back in and click the link that was sent to you in order to view the slide deck so that you can qualify for CE. After the webinar is complete, I'll review the attendance list and those who have qualified by attending at least 55 minutes and view the presentation. And you'll receive an email from me within the next day or two with specific instructions on how to access your CE credit on the ANP CE Center. There will be a passcode required and completion of an evaluation on the ANP CE Center in order to receive your CE credit. And in the meantime, if you have any questions, you can reach me by email at jreyes@aanp.org.
Thank you, Joseph. Appreciate you giving us that information. I wanted to just take a moment to talk a little bit about the national investment taking place for quality improvement in the United States with the help of our federal government and the organizations who are presenting this content today as part of the Transforming Clinical Practice Initiative, which is sponsoring today's presentation. The Transforming Clinical Practice Initiative, or TCPI, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and an enrollment of 150,000 plus providers across the country. The NNCC, or the National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programs to reduce health disparities and meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional membership organization for nurse practitioners of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 79,000 members. CMS funded the NNCC and the AANP to support enrollment of nurse practitioners into practice transformation networks, or PTNs, across the country to help develop specific educational material that facilitates practice transformation in advance of upcoming payment reform changes with CMS. The NNCC and the AANP are the only nursing-focused grantee of this TCPI project. The NNCC and the AANP agree that this initiative is important to ensure that nurse practitioners receive the support they need to remain competitive in a changing healthcare landscape. NPs are the future of primary care in the United States and already provide high quality and cost-effective care. This initiative is an opportunity for NPs to prove that by helping CMS and the broader healthcare community build the evidence based on practice transformation while preparing for value-based reimbursement. So how do we as NPs prepare for upcoming value-based reimbursement? We want to use this program to prepare clinicians across the country for payment reform under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. Hopefully many of you have heard of MACRA at this point. It's legislation that was passed to establish Medicare's Quality Payment Program, or the QPP. Under this Quality Payment Program, there are two payment adjustment mechanisms to incentivize quality-led care to Medicare Part B payments: MIPS, or Merit-Based Incentive Plans, and APMs, or Advanced Alternative Payment Models. Most clinicians will end up associated with MIPS, or the Merit-Based Incentive Plans. MIPS involves 4 elements, and clinicians will need to demonstrate successfully to maximize their Medicare Part B payments. These elements are quality, resource use, identifying clinical practice improvement, or CQI, activities that they are engaged in their practices, and the use of health IT effectively. If you can demonstrate these 4 elements in your practice, you can succeed in a value-based payment environment. So at this point, I would like to turn the presentation over to Dale Schaller. Dale?
Hey, thank you, Cheryl. It's a real pleasure for me to join your webinar series and to have the opportunity to speak with this group of nurse practitioners working on the front lines of primary care delivery. On the next slide, you'll see the agenda of topics that I'd like to cover, starting with a definition of patient experience, ways in which patient experience can be measured, and then a focus on the CAHPS Clinician and Group Survey, which is the survey instrument that's been designed for assessing patient experience in the ambulatory care setting. Then move into some of the policy and payment and market forces driving the use of CG-CAHPS, what Cheryl was just describing as the value-based payment environment that we're increasingly finding ourselves in. And then a brief review of some tools available for improvement, and hopefully at the end we'll have time for questions. So on the next slide, I wanted to position patient-centeredness and patient experience as one of the 6 aims identified by the Institute of Medicine, now the National Academy of Medicine, back in 2001 as central aims for improvement in the nation's healthcare system. And patient-centeredness is, in some ways, could be argued as really related to all of these aims, since providing safer care can be enhanced when patients communicate well and understand what their clinicians are asking them to do in terms of medications or reaching their care goals in a timely way. Patient-centeredness relates to effectiveness through enhanced communication between clinicians and patients about knowledge of medical history and other aspects of the care that they're receiving. Clearly, on timeliness, there are questions related to patient experience measures that relate to getting timely care as soon as needed and getting access to care after hours, for example, or getting the nurse's attention if you're in a hospital and you need help. And then also related to efficiency in terms of avoiding waste and possible additional unnecessary health care to the extent that patients and clinicians are on the same page with respect to their care plan. And because we ask questions in the surveys that I'm going to describe for you about respondents' age, education, race, ethnicity, we can actually also look at how equitably patient-centeredness is being delivered throughout the healthcare system. The next slide provides one definition of patient-centeredness by the Institute of Medicine, and it's actually one of the best. Many of these, there are many definitions of patient experience, and many of them are very similar. This stresses the importance of the partnership that's established between practitioners, patients, and their families, and ensuring that decisions respect patients' wants, needs, and preferences, and that patients have the education and support they need to make decisions and truly participate in their own care. On the next slide, I want to make a pretty important distinction because patient experience as a term is often conflated with patient satisfaction, and they're actually very different concepts. When we talk about patient experience, we're talking about what patients report about their care experience, whether something that should happen actually did happen and how often it happened. It's measured by frequency scales, and the CAHPS surveys use never to always on a scale of either 4 or 6 points, and allows this assessment to be really quite objective and apart from expectations. What patient satisfaction surveys have done over the years is really focus on much more of a rating aspect, whether a patient's expectations were met and whether they were pleased with the care that they received, often measured in terms of scales from poor to excellent, which are Likert type rating scales, and that's actually much more subjective than patient experience. The next slide talks about patient experience and how it relates to other important goals. We just talked about that with respect to the IOM aims, but I also wanted to mention there's a lot of research that's been completed in the last decade or two that shows the relationship between patient experience and other important health outcomes, whether patients actually adhere to medical advice, the relationship between patient experience scores and good progress on process of care measures, as well as clinical outcome measures. And there's also a pretty strong correlation with patient experience and other business outcomes with respect to, for example, patient loyalty, patient retention within a practice, enrollment or disenrollment rates within a health plan. There's evidence that doing well on patient experience actually reduces malpractice because of the improved relationship between patients and their providers. Strong evidence of a correlation between patient experience and employee experience, employee satisfaction. There's basically a one-to-one relationship there, and very good returns on the bottom line with respect to overall financial performance when an organization does well on treating its patients well. So there are a lot of good reasons to focus on patient experience, and the next slide basically says what really matters and why patient experience is important is because it does matter to patients and families. And so it's really important in its own right to be pursuing improvements in patient experience. So our next slide graphically shows the intersection of three kind of major ways of capturing or measuring the patient experience. One is the use of quantitative survey metrics, and that's going to be the focus of our webinar today with respect to the CAHPS survey. There's also increasing research underway, actually by colleagues of mine on the CAHPS team, on qualitative narrative feedback in terms of patient comments that add supplementary, complementary information to closed-ended patient survey scores. And then also an increasing role of patients that we're seeing throughout health systems in the U.S. with respect to putting patients on advisory panels, patient family advisory councils, embedding patients directly into quality improvement teams, engaging patients directly in what's called experience-based co-design, which is a method of healthcare transformation that's been pioneered in the United Kingdom and is finding its way now to the United States. But our focus today on the next slide, again, is on quantitative measures, thinking about standardized patient surveys, and there are a lot of proprietary tools out there, but most of them actually focus on satisfaction. And so back to the distinction I made just a few minutes earlier. Whereas in the public domain, we have instruments such as CAHPS, the Consumer Assessment of Healthcare Providers and Systems Survey, which really does focus on patient reports and patient experience as opposed to satisfaction. Mentioned the rising role of patient comments. We see increasing use of online sort of physician rating sites, the posting of online comments. Talk a little bit more about that in terms of our research within the CAHPS program on how to advance the science of that. And then there are many other approaches that can be used through targeted surveys that aren't necessarily sort of high stakes level, such as CAHPS, but sort of internal, very focused, rapid cycle turnaround surveys that actually allow organizations to sort of dive deeper on certain topics that they see revealed through patient experience scores, then moving into focus groups or interviews with patients to learn more, doing things like walking through and shadowing patients and the families as they move through the system from, the initial phone call to the parking lot to registration through the visit and beyond. And then some organizations are actually using mystery shoppers to, basically have someone kind of come in acting as a patient and making a lot of detailed observations and then feeding that information back to the organization for insights into how to improve. So let's focus now on the CAHPS program and move toward the CG-CAHPS survey and what that's all about and how that increasingly factors into your world of value-based payment. So CAHPS stands for the Consumer Assessment of Healthcare Providers and Systems. It's now the most widely used survey for assessing patient experience. It's been endorsed by the National Quality Forum. It's been around since 1995 through funding by the Agency for Healthcare Research and Quality, which is a federal agency within the Department of Health and Human Services. And it actually acts like a big consortium. It's got members, the project officers from EU. We have partners with CMS. The research teams are based at RAND, the Yale School of Public Health, and then support is provided through an organization based in Rockville, Maryland called WESTAT, which provides technical assistance and survey user education. So there's been a huge proliferation of CAHPS surveys since 1995 when it all really began with the original health plan enrollee survey, which was part of the Clinton era kind of managed healthcare reform approach to healthcare reform. Since then, versions of CAHPS have been developed and are now increasingly being implemented at the facility level. I'm sure you've heard of hospital CAHPS, HCAHPS, in-center dialysis units, nursing homes. There's a hospice CAHPS survey. And then within the ambulatory environment, there's increasing specialization of survey types, specifically for cancer care, which was released just last year, surgical care, dental care, and other programs and settings for the delivery of ambulatory services. So our focus today on clinician and group CAHPS derives from core design principles that are common to all CAHPS surveys. And we've touched on this already, but I want to emphasize that the focus of these surveys and these instruments are on what patients themselves want to know. And so we have done just hundreds of patient focus groups over the years and family input, stakeholder input to learn what it is that patients really want to know and what they value in seeking and receiving care from their providers. We focus then on the things that patients are the best and the only, or in many cases, the only source of information about those things. And so in that sense, this patient survey information complements other kinds of quality measures from clinical care to process measures to cost to safety. It's part of that sort of overall sort of matrix of thinking about ways of assessing overall quality. Again, the focus is on patient reports, not satisfaction. I've described this development and testing process, which relies on extensive patient input as well as stakeholder input. And it's important to note that all of these surveys and the services that are provided, funded by HRQ, are in the public domain. Everything is open to inspection. There's no black box. And we invite continually comments for improvements on the surveys themselves. So let's look briefly at the CG-CAHPS survey, which is the, again, survey designed for assessing patient experience within clinician group practices, medical practices, and it can be used to assess individual clinicians, be that a medical provider, a physician or nurse practitioner, or teams of care. And the kinds of content are shown here in terms of composite measures, and composites are basically, sort of think of them as summary measures of discrete questions that address specific topics that relate to each other. So the four major composites within the CG-CAHPS survey, the 3.0 version, relate to access to care, provider communication, coordination of care, office staff, which really refers to sort of the interaction kind of on the front line of clerks and receptionists. We have a single provider rating question, which can be used sort of as a bottom line assessment that you can relate these other kind of reporting composites to. And then each CAHPS survey, if it's relevant, has an adult and child version and a whole range of supplemental items that can be added to expand on the core. The adult core version of the CG-CAHPS 3.0 survey consists of 31 questions, which may sound like a lot, but it's actually a length that we have found is not at all a deterrent to completion of the survey. People worry about long surveys being sort of depressing response rates. And we honestly have seen a decline over the years in response rates overall, not necessarily, however, tied to the survey length. It's actually what we're finding more and more is it's tied to the survey quality. And we're pretty convinced that the CAHPS surveys are based on the science and the quality, and we're getting response rates that either match or exceed other shorter kinds of surveys that are often sent out by healthcare organizations. There is a resource that we provided as part of today's webcast that goes into detail about the CG-CAHPS questionnaire, so I'm not going to spend time doing that today. I do want to go on to the next slide, which shows kind of just a graphical way in which this idea of a core survey like CG-CAHPS 3.0 can be supplemented with items, CAHPS supplemental items, addressing a variety of topics, so that organizations can add to their core survey a custom set of survey questions to meet their specific practice needs. And examples of the kinds of supplemental item sets that have been developed and tested and made available again through the CAHPS site, free of charge, include patient-centered medical home items. Those are actually used by organizations like NCQA and URAC as part of their accreditation and certification programs. A set of questions on health information technology that gets into specific patient experiences using email, going online, reaching their office through other means than traditional kind of phone or direct visits. As organizations move more towards telehealth and non-office-based care delivery, those items become increasingly important. There are supplemental item sets related to health literacy, organizational health literacy, cultural competence, the use of interpreter services. And then one that I mentioned earlier that we're spending quite a bit of time on developing, which is what we call a narrative elicitation protocol, or we call it the NEP. I'll tell you about that in just a minute on the next slide, but here's a URL that actually takes you to the page on the CAHPS site, which allows you to look at all these supplemental item sets. And actually, there's kind of a tool that helps you sort of match supplemental items to whatever core survey that you're using, trying to make it as easy as possible for organizations to create their own versions. So just a few words on the narrative elicitation protocol. What we've learned with the standardized closed-ended survey questions that are central to CAHPS and actually vital to being able to actually score and compare organizations' performance. You have to have some quantitative way to do that. What we find is that healthcare practitioners often find most valuable, I mean, they understand the scores because they're in many cases required, but in order to understand what to do about the scores, understanding what patients say in their own words is very helpful. It gives them insights and ideas about what they can do to improve, sort of unpacks what's going on into these numerical scores to provide an underlying story of what the patient's experience is. So lots of surveys have opportunities for, well, give us one last comment on what you think we can do to improve. That's pretty typical. What we've developed is a series of 5 open-ended questions that actually kind of are structured together that prompt the survey respondent at the end of the survey to describe what they're looking for, whether their expectations are met, what particularly went well, what could be improved, and then describe their interrelationship with themselves and their provider. What we've learned in the testing of this protocol is that we get really high quality information from patients in their own words that actually matches well against what we call a gold standard interview, where we would talk to the same set of patients responding to these 5 questions, and then an intensive interview, see, over a period of an hour with trained qualitative interviewers, whether or not those 5 questions actually gave us the essence of what could be gleaned with an hour conversation. And the correspondence rates are exceedingly high, between 60 and 80%. So we're testing this protocol right now in the field with New York Presbyterian Hospital in their ambulatory care network to see how well it actually works in practice when part of sort of ongoing survey operations. And so, we'll be talking a lot about that in future publications, and hoping to, maybe we'll do another webcast with you on how well that narrative elicitation protocol actually performs in practice. So the next segment of today's webcast, I want to just sort of review the environment that's driving the use of CAHPS, in particular CG-CAHPS. Cheryl indicated some of those forces at work in the intro to the webinar. And I think we can think about them in 4 different ways. There's increasing movement toward transparency and public reporting, value-based purchasing, the role of recognition and certification programs, and I think, not to be underestimated, a very strong and growing patient and consumer demand for information and responsiveness, sort of in service delivery among the healthcare organizations that they use. The next slide shows the evidence that there's an increasing consensus on CAHPS as a sort of the one of the measures of choice for getting at patient-centeredness within ambulatory care. The NQF National Priorities Partnership has advocated use of CG-CAHPS as a top priority. The Measure Applications Partnership, which is also affiliated with NQF and advises CMS and federal programs on the use of performance measures, has recommended the use of CG-CAHPS in all of the clinician performance measurement programs that CMS manages. And of course, patient centeredness is an integral part of the healthcare quality triple aim, and now the quadruple aim, which recognizes the importance of provider experience as well. We also see a growing consensus within a collaborative that has brought together multiple stakeholders, led by CMS, the America's Health Insurance Plans, and the National Quality Forum, to kind of try to get at alignment of measure requirements, so that there's a core set of measures that all programs, federal, state, public, private, can rely on, so that organizations aren't facing just multiple, oftentimes conflicting or slightly different external demands for measuring and reporting on their quality. So within this collaborative, CG-CAHPS was included in the core set of measures that were agreed to be core for ACO, patient-centered medical home, and primary care measures. With respect to public reporting of these measures, probably one of the more important initiatives that's been underway for now the last decade, almost the last decade, through establishment of the Affordable Care Act, is the Physician Compare Site, which is one of the many Medicare compare sites or CMS compare sites that CMS sponsors. Organizations that are participating in the ACO or what was now formerly the PQRS program, now known as MIPS, which Cheryl mentioned, and we'll talk about in a moment. Previously were required, if you're an ACO, you actually have to use the ACO version of clinician group CAHPS, and those scores then are publicly reported on Physician Compare. Groups of 100 or more eligible professionals were required to use CG-CAHPS and submit that information, and that information is now publicly available on Physician Compare. The new guidelines that are, or rules governing the MIPS program don't make CG-CAHPS a requirement, but rather a high priority measure within the quality improvement domain. And so there's extra new CG-CAHPS, and that would eventually find its way onto Physician Compare if it meets the test of reliability for public reporting. Outside of CMS and what the Physician Compare site is doing, there's a lot of public reporting happening at the state level. Here's a slide that shows sort of what at one point 5 years ago were 16 individual regional coalitions around the country that were either voluntarily or, in the case of Minnesota, were mandating the collection and reporting of CG-CAHPS for basically public transparency purposes. Many of these organizations continue. They were all part of the Aligning Forces for Quality program that the Robert Wood Johnson funded from 2007 through 2015. That program has ended, but many of these community regional efforts continue with their public or regional public reporting of clinician and group CAHPS survey measures. And then the next slide digs a little bit deeper into the value-based payment programs through not only CMS, but increasingly we see among commercial health plans and payers as part of their pay-for-performance programs. So if you are an organization, if you're a clinician involved in an ACO, I've already mentioned that the clinician and group CAHPS survey for ACOs is one of the required performance domains. So that information is being collected, reported, and used for adjusting ACO payment. What's happening with MACRA, as Cheryl referred to, right now it's kind of in flux. HHS was a huge proponent of value-based payment in the Obama era. Current leadership within CMS is taking a little bit more of a, let's see if we can winnow the number of quality measures we use. Let's see if we can make some of this stuff more voluntary than required. And so a lot of the rules are in flux. The merit-based incentive payment systems, or MIPS program, which is an opportunity for small practices and individual clinicians to participate in this kind of pay-for-performance program, as I noted earlier, counts CG-CAHPS toward its quality requirement as a high priority measure. So you get extra points if you do it, but it's not required. And so if you're in an advanced alternative payment model, I think there's also flexibility. It's not required. There's this kind of a voluntary selection of CG-CAHPS for use in meeting the quality reporting requirements of the APMs. But there are incentives to do so. And again, sort of the environment for this whole macro-generated set of payment programs is in flux. And actually most recently, there was even pushback from the Medicare Payment Advisory Commission, which is a national body advising CMS, HHS on value-based payment for Medicare. It has suggested that the MIPS program basically be carefully reviewed and kind of reorganized. So there are a couple of other initiatives out there that may or may not affect you depending on where your practice is. CMMI, which is the Innovation Center arm of CMS, is now into the first year of this 5-year Comprehensive Primary Care Plus program, which is all about finding, developing, testing, rewarding new approaches to the delivery of primary care. It's an alignment with multiple payers. It's not just CMS, but it's a partnership among multiple payers in 14 different regions. And almost 3,000 individual medical practices are now part of this program. And CG-CAHPS is a fundamental part of the quality measurement, evaluation, and payment formulas that are used under CPC+. And as I mentioned, a number of commercial health plans have been using CAHPS in their P4P, pay for performance programs, and from California to Massachusetts. This is not a new thing. It continues to evolve, and I think we will see both public and private programs with respect to value-based payment continue to evolve in the next, as we move forward into the next several years. So finally, I want to, having talked about what patient experience is, how it can be defined, how it can be measured, to focus on CG-CAHPS, the environment for CG-CAHPS, let me touch just a little bit on, so if you're doing this and you're being scored and evaluated, or you're using it internally for improvement, what are tools that are available to help you basically along the way? This slide shows a screenshot of an inventory that a team of mine put together for the Robert Wood Johnson Aligning Forces for Quality program when it was around, but that toolkit is still available at this URL, and includes a lot of resources that are available free of charge. They're all in the public domain for improving patient experience, not only in the ambulatory environment, but in the inpatient environment as well. The next slide describes what we call the CAHPS Improvement Guide. It's geared toward ambulatory care improvement strategies. It basically, it's an online tool, which we are now turning into a PDF for downloading off of the CAHPS site, which presents kind of an overall context for improvement at the organizational level, what's needed, suggestions for analysis of patient experience survey scores, as well as other forms of patient feedback. And then the sort of the heart of the guide is a set of strategies or interventions that are mapped to specific components or composite areas of the CAHPS survey that we just described. And we've been updating this guide over the last decade, and we'll continue to do so. And what we've heard and what we've been monitoring through the sort of access to the CAHPS site is that this is the most popular, most downloaded tool on the CAHPS site, and highly recommend it for kind of an overall manual to help you get started on strategies for improving your CAHPS scores. And then the last resource I'm going to mention is what we call the CG-CAHPS survey database. I've had the privilege of serving as the managing director of the CAHPS database since it was started back in 1998. It's funded by AHRQ as part of the CAHPS user network. It's a free service open to all survey users for selected surveys. We don't support all CAHPS surveys, but we do the clinician group survey that we've been talking about, as well as the CAHPS health plan survey administered to Medicaid and CHIP programs. If you work with a vendor, if you're using CG-CAHPS, you can have them sort of as a voluntary program, have them submit your data according to our submission specifications once a year. And we usually have the cycle running with submissions in early March with reporting in June. We're actually in 2018 moving that back to May of this year in order to accommodate the big CPC Plus program I just described, which will be gathering and submitting a lot of data for practices around the country. So if you do the submission and you are a participant, you can access comparative results and actually look at a private feedback report that's customized to your scores, to your organization, which is a great benefit to many organizations that can't afford a survey vendor with kind of online sort of portals for looking at your scores, in real time. There are survey vendors that do that for their clients. This is an opportunity to add comparative data, again, available in the public domain, not related to an individual survey vendor, but captured for all users of CAHPS surveys that choose to participate in the CAHPS database. So one example of the products that we produce was, we call it Chartbook, which in addition to the online reporting platform that's available to look at your scores, we produce kind of a summary level Chartbook that has bar charts that anybody can access to compare their scores to kind of summary level measures composed of all the contributors to that particular database. And we do further analysis by state, specialty, provider type. We put together trend graphs when trend data are available. This is also included in your resources for the webcast as something that you can look at that you don't have to go searching for. So that is my prepared part of today's webinar, and I'm going to stop there, and hopefully you have questions or comments so we can actually talk about it as in the remaining time.
Thank you, Dale. That was really wonderful and a great overview of CAHPS and just the important role that it plays, particularly with payment reform and upcoming changes for MIPS and MACRA. One thing I just wanted to mention to everyone, and just a reminder that you can submit your questions through the question box. We'll take a moment for people to go ahead and do that and submit any questions that they may have for Dale. One thing I kind of wanted to start us out with, Dale, in terms of a question that I'm wondering about, because we do, as the NP Support and Alignment Network, we work closely with some small and rural practices to become compliant for MIPS and MACRA. And I'm just wondering if there's any words of wisdom, or if you've had experience in either working with small or rural-based clinics and how this, how they might best access this as a resource.
Well, I think it's a great question. There would be nothing different about the tools and resources available to small and rural practices that would be available to large academic health centers. So, just to reiterate the point that all of the CAHPS materials, the surveys, the guidance documents, the resources, the tools that I've described are available. What often is the most difficult obstacle, even though the CAHPS program makes the materials and the survey instruments available free of charge, actually collecting the data does require some resources. Practices generally hire a survey vendor to do this because of the specialized nature of drawing a sample, fielding the survey, getting the data back, analyzing the data, and creating a report. There are practices that have successfully done this on their own. One that comes to mind is there's an organization called the Community Oncology Alliance that works with oncology centers around the country, and they basically they act as a resource to help organizations field the survey. They have a little kind of benchmarking database of their own and provide feedback reports as well as contribute to the CAHPS database. There's in some ways, Cheryl, if you're going to use the CAHPS survey in a way that is compliant with sort of these program requirements that we've been describing, there's a certain threshold of cost that's involved, and so we are working on on multiple fronts to find ways to make the collection of CAHPS surveys more affordable. And one way to do that is to use email addresses of patients if they're available. What we've learned is that using email as an efficient way of contacting people and asking them to complete a survey online really depends on having patients' email addresses. And a lot of practice systems haven't even had a field available until recently for capturing patient emails. So one very important first step for all practices, small and large, is to begin collecting email addresses and then be able to use the email administration protocol that we've developed for a much cheaper way of reaching out to their patient population. So there's no silver bullet here though, and I don't want to pretend there is. There are ways in which smaller rural practices can find sort of shortcuts. I think email administration is one. Working with a consortium of other practices and maybe being able to pool resources to hire a vendor in common. We've seen this work in consortia, not necessarily in a rural area in the past, but through professional societies and through state coalitions. You can drive down the cost of administration by having multiple clinics or practices together, hiring a vendor and sort of, basically reduce the shared cost. So those are some thoughts that come to mind. I'll stop there and see if that helps at all.
Great. Yeah, no, I think that's perfect. And I think that, there are still many practices out there nationally that do not have an electronic database. So even the act of, collecting email addresses as we work through this process to get into, digitizing what we're doing in the medical communities, I think that's a really practical first step. Another question that I had, just wondering again, since you've been doing this for quite some time, and wondering if you have, or if you do ever get any feedback on some of the CAHPS parameters that are used, some of the questions that are either most commonly used or feedback you get from patients that has actually changed practice, if there's a particular area of CAHPS, say around patient engagement, that you've seen in your experience that's really caused a change kind of in the quality improvement side of the house in practices? Yeah,
it's a great question. And I mentioned in my presentation that the development of CAHPS surveys goes through this pretty rigorous process of, asking patients through focus groups, interviews, cognitive testing, what is most important to them. Having done this for over 2 decades, what it all really does come down to are 2 things. There's a lot of stuff, but if you had to go to the heart of patient experience, the first thing is communication between the patient and their practitioner. The other one that's increasingly becoming an issue for improvement, where there are huge gaps remaining, is coordination of care and transitions of care. Actually, difficult concepts to capture from the patient perspective, because when coordination is done well and seamlessly, patients don't really see it. It's when things don't go well that they see it. And that's when I think the idea of now having a core composite on care coordination that asks specific questions that can be generalized enough to apply to enough patients that you can actually get good data. So we use, did the provider seem up to date on your medical history as one example of a question that kind of gets at, do they know you? Do they understand what's going on with care they're receiving from other providers, et cetera? But the use of this new narrative protocol, where we're actually asking patients to expand, is also, I think, a huge leap forward in terms of identifying ways in which organizations can improve. But let me step back to the communication piece again. When you look at CAHPS data and you you do what we call correlation analysis or key driver analysis, which is internally what are the elements of the survey that have the most pronounced association with an overall rating question for the practice or the provider. It always comes down to communication. And it's actually, while it's the most important, probably component of patient experience, it you know, and I think your audience might even relate to this, it's actually one of the most difficult things to improve because of the way in which clinicians are trained, the practice styles that they adopt, the culture in which they find themselves, getting them to step out of certain communication behaviors, get off the computer terminal, actually spend time listening, relating to their patients. That's what we all look for in good primary care. Yet it is a skill set. It can be taught. It can be learned, but it often is innate. And so that's why we see communication. We see big differences in communication scores. We also see the difficulty of improving communication. But when you do, when you make that your focus, you will lift up everything else in your practice because it all kind of hinges on that.
Great, thanks so much, Dale. We've got a couple of questions that are coming in, and I'll just go ahead and start from the top. Margaret is asking more of a logistical question with regards to how to disseminate the CAHPS survey. Margaret is asking, are CAHPS surveys sent to patients electronically and by paper, or is one medium used over another?
Okay, so we touched on there is increasing interest in use of e-modes of survey administration, and that can be done through sending an email to a patient, basically with an invitation that contains a URL, that's a hot link to a website that then the patient can complete the survey online. I would say that that is a mode that is growing rapidly, but the still dominant mode of survey administration and the ones that are kind of accepted for high stakes public reporting and payment by federal and state programs are paper, basically, mailing out a survey in paper format to a patient's address. Telephone administration is often used as a follow-up when mail returns aren't met. So those are the two most dominant modes. They're also the two most expensive modes. So that's why we're seeing increasing movement toward e-administration. There's another mode called IVR, interactive voice recognition, and there's two forms of that. One is voice activated recognition, voice IVR, and one is touchtone. And what we're finding is that touchtone is actually doesn't work as well, because if you think about it, if you're manipulating a keypad and you're trying to hit the right keys, it's not great for a lot of people. Voice activation is a lot easier. You're just using your handset to answer verbally among the options provided. So those are the main forms of administration: mail, phone, IVR, and email administration. Let me also make a comment, because, and I could have mentioned this in the context of Cheryl's small rural practice. A lot of organizations think, understandably, that, oh, well, we'll just do this kind of through handout in our office practice, which you can do. Organizations have done this for years. They basically will, hand a survey out to the patient after their visit and ask them to either drop it in a box or mail it back. Here's the problem with that. It sounds cheap. It actually is hard to do it's hard to do well, period, because you have to train your office practice personnel to remember to actually hand the survey out. It could be attached to after visit survey form. That's if you're electronically set up to do that. But here's the real problem with in-office distribution is actually costs a lot in terms of personnel time and logistics that are more invisible than just buying the services of a vendor. But the reliability of results, even from within one medical group, let's say with multiple practices, and we've done several studies published in the peer-reviewed literature that has looked at sort of a comparison of different survey administration modes, including in-office distribution. And what we find is that in-office distribution is the most unreliable way of gathering survey data because of things that you just cannot control within the practice culture. So the best way to do this is through some independent third-party means by hiring a vendor using one of the modes that I've described. It takes it off of the shoulders of the individual practice, and it puts it in a more neutral setting. You get better, higher quality results that way. If you're participating in these mandated programs, you don't have any choice because CMS will require you to use one of those modes. So again, I hope that's helpful.
Great, thanks so much, Dale. And we just have about 4 minutes, 3 or 4 minutes left, and a handful of questions. So we most definitely won't have enough time to get to all of them, but we'll make sure, for those of you on the line, we'll be forwarding the remaining questions to Dale, and Dale will be providing us with answers, and we'll make sure to get those responses to you in the next, I don't know, week or so. But we probably have time for maybe 1 or 2 questions left, Dale, if you can maybe just be a little bit more concise with your answers.
Sure.
So this next question comes from Karen. I'm just going to go ahead and read her question.
Okay.
Regarding provider satisfaction, do you see any movement to lift the 15% penalty to nurse practitioners who bill their services directly with their own provider ID number instead of under providers' ID number? The incident to billing function is really hard on practitioners who do use incident to billing, and I think the incident to billing should no longer be relevant. So any thoughts on that as it relates to the CG-CAHPS survey?
I don't. So quick answer is I just don't have any information to be able to answer that usefully. So I apologize. I don't know.
Cheryl, did you want to chime in to contribute anything to that?
The only thing I would say on that is, again, you need to be an informed provider. So if you are collecting CAHPS data in your work environment, it behooves you to find out, 1, what's being collected, how it's being collected, and how they're identifying the providers within the practice. And I think that will give you your information. Oftentimes, like so many things, if you are being billed incident to, you need to know that as a provider so you can advocate for that not to be the case. And particularly around patient satisfaction, that's one of the areas that we as NPs really need to push forward and get good data, but we are often stuck under another TIN number, so that data is not always obvious. So I would say just advocate for yourself, go to your practice, ask some questions so that your data, your patient information data can be collected separately, and so there'll be some good data in the practice.
And probably the last question, it's a quick one. Myra is asking, she was trying to jot down some open-ended questions that you had referenced, Dale, in the presentation. So she wanted to ask if you can recap the 5 open-ended questions that are in the survey. She jotted down a couple of them, but not all of them. I'm happy to show the slide if you can direct me as well.
Well, in shorthand, the 5 questions are, first of all, what is it that you look for in your provider or office and their office staff? Second question is how well do you think those expectations are met? The third question is, what can you tell us that has gone particularly well in the last however many months, 6 months or 12 months, depending on the time frame of the survey? The fourth question is what things could have gone better, why, and there's some probes on that. And the fifth question is, can you describe how you and your provider interact with each other? Now, the CAHPS website and the URL is actually found in different places within the resources, within these slides and the resources that were provided. has has a much more detailed description of that protocol, and if I can actually send that to you, Cheryl, Tiffany, if you want, and then you can distribute that, or we can distribute the URL so that people don't have to search around for it.
That would be great if you could do that to us offline, and we can certainly get that information back to our providers. In closing here, and I just again wanted to thank Dale for this really wonderful information. It's so important for all of us to know and be advocates. If anyone has any questions about TCPI or our group, the Nurse Practitioner Support and Alignment Network, our emails are listed there. Also, too, if you wanted to get a little bit more information about AANP and what they're doing, if you go to that link at the bottom and just kind of read through what's going on with practice transformation as well as payment reform, there's a nice overview. So you can talk with some authority in your practices about what it is and what's going on, and we should all be informed providers. And lastly, I just wanted to let everybody know that next month we will be sponsoring Cindy Brock, who is a senior health policy researcher at AHRQ. And we'll be talking about patient health literacy, particularly in primary care settings. So I just want to say again on behalf of the NNCC and the AANP, I just wanted to thank Dale again for this great presentation, very timely, important information for all of us. Look for the Vimeo recording, and also we'll be looking for the survey for your comments and input. I thank everybody again for joining us today, and have a great afternoon. Thanks all. Goodbye.